All right. Very good morning, ladies and gentlemen, and thank you for joining us on the third day of the Malaysian chapter of this World Allergy Week 2022. We were supposed to go live slightly earlier, but due to technical difficulties, here we are. But nevertheless, we are happy and excited to share this event with all of you, wherever you may be joining us from. So in today's event, we will start off with a welcome note from the President of the Malaysian Society of Allergy and Immunology, Dr. Kent Wu, followed by a welcome note by a very distinguished guest, who is Professor Ruby Pawankar. She is the current president of the Asia Pacific Association of Allergy, Asthma and Clinical Immunology, and the past president of the World Allergy Organization. After her welcome speech, she will then follow on with an expert talk focusing on allergy and allergic rhinitis and asthma. Just take a few minutes to share my screen here. So we'll start off with a welcome note by Dr. Kent Wu. Dr. Kent graduated from the medical school at Thomas Jefferson University, Philadelphia. He then obtained his internal medicine residency training at Eastern Virginia Medical School, where he was nominated by his peers to serve as chief resident of internal medicine. Subsequently, he served as an assistant professor of medicine and developed the academic hospitalist program at Norfolk General Hospital in Virginia. Later on, Dr. Wu pursued further subspecialty training in the field of allergy and immunology at Louisiana State University. He was inducted as a member of the Alpha Omega Alpha Honor Medical Society for his excellence in medicine. Dr. Wu is a board-certified member by the American Board of Internal Medicine and the American Board of Allergy and Immunology. He was also awarded a diploma in clinical dermatology with a distinction from the Queen Mary University of London. Dr. Kent Wu is currently the president of the Malaysian Society of Allergy and Immunology, fondly known as MASAI. He sees both pediatric and adult patients with allergic diseases at the Gleneagles Hospital in Kuala Lumpur. We'll now listen to a pre-recorded welcome note by Dr. Kent Wu.
Hello, I am Dr. Kent Wu, and I'm the current president of the Malaysian Society of Allergy and Immunology. And on behalf of the society, I'd like to welcome all of you guests in joining us today in this event, Breathe Better. This event is organized in conjunction with the World Allergy Week, organized by the World Allergy Organization. In today's event, we have an expert panel who will be sharing with us information on allergies and how it can affect your respiratory tract and how it can affect breathing. We're also going to see some breathing exercises that all of you viewers can attempt to do in the comfort of your home. We also hope that this is one of the many upcoming events in which you can join us to learn more about allergic diseases. I'd like to thank all the expert panel speakers who have taken time off to join us today. And without further ado, let's proceed on to the program. Please sit back and enjoy a very well-planned program for you. And if you have any questions, please do not hesitate to reach out to us later on. Thank you very much.
Well, thank you very much indeed, Dr. Kent Wu, for the very welcoming speech to the World Allergy Week 2022 Malaysian chapter. Following Dr. Kent's speech, it is my great pleasure and honor to welcome Professor Dr. Ruby Pawankar to then provide her welcome note, followed by an expert talk. Professor Ruby is someone who requires no introduction in the field of allergy and immunology. Nevertheless, I feel obliged to tell you a little bit about Professor Ruby. She is the president of the Asia Pacific Association of Allergy, Asthma, and Clinical Immunology, otherwise known as APAAACI. She was also the past president of the World Allergy Organization between the years of 2012 to 2013. Apart from that, she is a council member of the Collegium International Allergocium. She is currently a professor at the Department of Pediatrics at the Nippon Medical School at Tokyo, and a guest professor at Showa University School of Medicine, Tokyo, as well as an honorary professor at Capital Medical University, Beijing, China. In her career, she has won many awards, and some of the major awards are the World Allergy Organization Gold Medal Award, the Pravasi Bharatiya Saman Award in Medicine from the President of India, and an International Distinguished Fellow Award of the American College of Allergy, Asthma, and Immunology. She has published widely, reaching close to 600 publications with over 43,000 citations, and is editor of various journals in allergy and immunology, books, as well as contributes to the World Allergy Organization White Book on Allergy and updates on respiratory disorders. Without further ado, I would like to then move on to Prof. Ruby. Prof. Ruby, would you be able to share your video?
Thank you very much, Dr. Kavita. That was a wonderful introduction, and thank you very much to Dr. Kent for his welcome address. MASAI is a very important organization of the World Allergy Organization as well as of APAACI, and we're very proud to have MASAI as a very active member of APAACI, and recently also organized the APAACI Allergy Week about 2 weeks back. So it's my pleasure today to welcome everybody to this World Allergy Week seminar, and this whole week. Multiple events are happening across the world, and this is of course in Malaysia. To just say a few words about World Allergy Week. Having worked 17 years in the organization, World Allergy Week was initially a World Allergy Day, and sometime in 2005, the board decided that we should have something like a week, and this was discussed in the board. And then in 2011, we had the first World Allergy Week that was celebrated across the world. And since then, annually, World Allergy Week is held every year on a different theme, a specific theme, and with all its member societies. So this year it's about asthma and allergic rhinitis. And that brings me back to something even more close also to my heart as a topic is rhinitis and asthma, the link. And the most important of that is the ARIA guidelines led by Professor John Bousquet and Paul van Kommenberg initially, and of course, continuously led by Professor John Bousquet and the ARIA team. And I was part of the team that actually wrote the guidelines in 1999 at the World Health Organization. But the link between allergic rhinitis and asthma is not new. That's been talked about for years. But the evidence-based guidelines of ARIA actually happened in 1999 and was published in 2001. So what I'll try to talk in this little time here is just an overview of allergic rhinitis and asthma, what's its prevalence, what's its burden, a little bit about the link, the mechanisms, and of course, about the pharmacotherapy and not much about biologics, but a little bit about intro about immunotherapy. So we all know about the atopic march, and this is actually becoming even more complicated now because it's not the same as what we thought of before. Earlier on, the atopic march would usually be like starting with eczema and then followed by food allergy and asthma and rhinitis. Now we can see in small children that many of this occurring at the same time. Although it's more difficult to diagnose asthma in less than 5 years old or rhinitis, now do you see rhinitis even in children as young as 2 years old? So they get sensitized earlier, they have symptoms earlier, and asthma rhinitis is often coexistent in many of these children, and controlling rhinitis has proven to, even clinically and also through scientific evidence, to have benefits on asthma control. So even though this typical atopic march is there, nowadays we do get different varying patterns, and also the sensitization patterns vary a lot. For example, in Japan, where I live, peanut allergy was never an allergen causing food allergy in, say, 20 years back, but now you can find many more children suffering from peanut allergies. Now, looking at this allergy, a major global health problem, this was published in the WOW, a white book, which was edited by myself, Professor Walter Canonica, Stephen Holgate, and Richard Locke, and then later on also by Dr. Michael Blaze, who joined us, and is a very important source of information that gives you an overview of all the different allergic diseases. So in this, we have actually highlighted the burden of asthma and allergic rhinitis. And as you can see, across the different continents, there is a huge burden. And this burden of total cost means indirect and direct cost. The direct cost comes from the disease itself, and indirect and the treatment, and the indirect cost from loss of work productivity or loss of school days and so on, and a reduced quality of life. Now, when we talk about rhinitis, like many other diseases like asthma, has phenotypes. So the phenotypes of rhinitis, so it's not all allergic rhinitis. You have allergic rhinitis, you have non-allergic rhinitis, you have mixed rhinitis, you have infectious rhinitis, and of course, the other factors inside the nose, like the turbinate, hypertrophied nasal turbinate, a deviated nasal septum, or the presence of adenoid hypertrophies in children, all these can further amplify the severity of the nasal symptoms. When you talk about the pathomechanisms of allergic rhinitis, well, the allergen actually triggers a sensitized mast cell, to which it binds to the IgE receptor on the surface of the mast cell, releasing the mediators that then further lead on to the release of histamine, prostaglandins, leukotrienes, and then a variety of cytokines too. So the initial phase or the early phase response occurs in as less than 30 seconds to about an hour and lasts for about 2 to 3 hours. And then after 3 to 4 hours, you have the late phase reaction, which goes on to about 18 to 24 hours, actually instrumentated by a variety of infiltrating cells that come from the peripheral blood into the tissue. And as you can see here, ultimately, it's not just the cells over here, like the T cells and the mast cells that are in the tissue, but eosinophils and basophils also play an important role. And we now know over the years, over 20 years on and plus, we know that epithelial cells are no longer just a barrier, just a cell on the outer surface, but plays a very important role in the barrier, as well as in protecting the barrier against foreign substances, but also as an important immune cell by releasing TSLP, IL-25, IL-33, and so on. And the immune cell, epithelial cell interaction also plays an important role when you talk about protecting the body against this thing, or even maintaining the homeostasis and the extravascular vesicles, as well as the interaction with the microbiome. So what are the triggers? We all know these triggers. The outdoor allergens are usually pollens and molds, and the indoor allergens are usually house dust mite, animal dander, and insects like cockroaches. And of course, non-steroidal and anti-inflammatory drugs like NSAIDs can also cause aspirin-induced rhinitis or rhinosinusitis and asthma. Now, when you talk about the link between rhinitis and asthma, we know there is a link. Like about 40% of allergic rhinitis patients have asthma, and about 80% of asthmatics have allergic rhinitis. So it's very high percentage of coexistent asthma and allergic rhinitis. Now, if you can see here that the mast cells, of course, then trigger the T cells, TS2 type cells, and these TS2 type cells migrate to the bone marrow, and then they actually enter the peripheral blood, cause the progenitor cells to enter the peripheral blood, like the progenitors of eosinophils and basophils, and then these get matured in the peripheral blood. So normally eosinophils and basophils are not found in the tissue, they are in the peripheral blood, but then they come into the tissue when there is inflammation. And this inflammation occurs because of an upregulation of adhesion molecules like ICAM1 or VCAM1, and the release of chemokines and other cytokines that actually pull in these kind of cells into the tissue and cause the ongoing chronic inflammation. So what's the impact of allergic rhinitis on asthma in a child's quality of life? Well, children and adults are both affected by it. And this is a study done by Erika Valavita and me and several others in this region in Asia as well as in Europe. And this is the Asian data. And as you can see here very clearly, this is when the disturbance in the quality of life when the children had only asthma. But when they had asthma and rhinitis, more than 80% disruption of the quality of life, showing clearly that while allergic rhinitis is not a life-threatening disease, it actually impairs the quality of life, impairs the work productivity, impairs the learning performance, and also has acts as a risk factor for asthma. And so asthma control requires the control of allergic rhinitis. And we all know the classification of ARIA, so I'm not going to talk about it. We know that it's classified into intermittent and persistent, mild and moderate severe, intermittent, and mild and moderate severe persistent. And this classification is based on the duration. So it's not equal to seasonal and perennial. Means seasonal is not equal to intermittent, and perennial is not equal to persistent, because there are many grass pollens that are present throughout the year, and they would be classified into the persistent group. And in some places, house dust mite may just affect a certain period, and then it would come in the intermittent group. So they're entirely different. So the seasonal and perennial are based on the allergens, and intermittent and persistent is based on the duration. Now, when you talk about the management of allergic rhinitis ARIA, you can see that this is the different type of treatments like oral antihistamines, intranasal, ocular, intranasal steroids, and a combination of them, nasal decongestants, and chromones, leukotriene receptor antagonists, and intranasal anticholinergic. To just make it simpler and for want of time, just to highlight that intranasal antihistamines are effective in rhinorrhea, sneezing, nasal itch, and nasal obstruction. Oral antihistamines are also highly effective in all these symptoms, but when it comes to nasal obstruction, intranasal corticosteroids are much more effective. Now, we do use combination of intranasal corticosteroids and intranasal oral antihistamines in more severe disease, but the evidence of whether intranasal corticosteroids and intranasal antihistamines are effective shows that the combination is pretty good and is fast acting. Nasal decongestants are not really recommended because of their rhinitis medicamentosa. If at all you have to use it for very severe nasal obstruction, acute severe obstruction, use it for less than 7 days and then give a gap because it only treats the nasal obstruction. Chromones in general are not recommended because of their multiple times they need to be used and the relative compliance issue and less effectiveness. Leukotriene receptor antagonists are good when it comes to patients who have both asthma and allergic rhinitis. And then this is the way in which you would treat. For the more mild, you start with an oral or a local non-sedative second generation antihistamine. And then, of course, moderate to severe intermittent and mild persistent and so on, you would add an intranasal steroid in combination or an anti-leukotriene that you can use. And then, of course, immunotherapy is given in more persistent rhinitis. And I will come to that later. Now, what about children? Often parents are very concerned, how long can my child have antihistamines? Is it safe to have antihistamines for a long time? And does it improve the lower respiratory symptoms? Yes, I mean, antihistamines don't directly treat asthma, but by controlling the allergic rhinitis, it has an indirect effect on improving the asthma control. On the other hand, the second generation antihistamines that do not have sedative effects and that have good anti-inflammatory effects and have much lower bioavailability as compared to other are much safer and recommended in children and can be used for longer time. And this has been shown by in different studies. So it is safe to use them in children as second generation antihistamines, and they do control the asthma symptoms indirectly by controlling the rhinitis. Yes, they can improve the quality of life. Treatment of allergic rhinitis in children would improve the quality of life because allergic rhinitis worsens the quality of life. Treatment with first generation antihistamines are not recommended. As I said already, that has sedative effects, and second generation antihistamines are the treatment of choice. And then, of course, you can give intranasal corticosteroids also that are very effective. Now, let's look at the next generation of the ARIA guidelines, which actually looks at a more higher level of evidence, that is the GRADE approach, which is the recently higher level of evidence as compared to what we used in the initial ARIA guideline, and then also real world evidence, because in a controlled study, randomized control study, you're putting all the patients in a certain group, whereas the real world evidence is also very important because you're looking at the real situation where a patient has multiple different comorbidities of different diseases, and you're seeing the effect in such a situation. And what I'd just like to highlight out here are some things. Like oral antihistamines are less potent than intranasal corticosteroids. This has been shown with grade 5 evidence in RCT as well as real world data. Then intranasal antihistamines are less effective than intranasal corticosteroids. Again, this has been shown with that evidence. Intranasal corticosteroids are potent medications, first-line therapy in moderate severe. Again, this has been shown with grade 5 in both the randomized controlled and real-world data. What about combination of intranasal corticosteroids and oral antihistamines? Does it have an advantage over INCS alone? It doesn't show any advantage over INCS alone because INCS alone can control many of these symptoms. But depending on the symptoms, sometimes you need to add an oral antihistamine together with the intranasal corticosteroid. And then again, you can see that the other ones are with limited restrictions, so I will not go into that for want of time. Now we're moving away a lot from disease control to try to make closer to disease cure. Not cure really, because allergy cannot be cured, but closest to cure is trying to maintain periods, longer periods of disease, almost no symptom-free period for several years. And how can you achieve that? And immunotherapy is the first prototype of precision medicine. We are now in an era of precision medicine with biologics like omalizumab, anti-IgE, like anti-IL-5, like dupilumab in multiple diseases, whether it's rhinitis or chronic rhinosinusitis, asthma, urticaria, atopic dermatitis, and so on. So allergen immunotherapy is tailored to the specific IgE. So specific allergen, specific IgE. So in 2009 was the first sublingual immunotherapy World Allergy Organization position paper led by Professor Walter Canonica. And that same guideline, which was evidence-based, was then published again, reevaluated and published again in 2013. And let me give you some highlights about it. So some of the highlights about it is that the age does not matter to be a limitation. So generally, we would say 5 years and above are okay to give slit. But of course, even 3 years and above have shown improvement. Monosensitized and polysensitized are both correct candidates. And of course, it can be used outside of rhinitis and asthma for other forms of allergic diseases. But what I'd like to highlight here is this particular point. Initially, one would always say that failure of pharmacotherapy is the way to go to immunotherapy, but that's not necessarily the situation. You can offer immunotherapy as a choice for your patient by telling them that that is the one that's closest to cure, that would give you a long-term symptom-free period, even after stopping the treatment if taken over 3 years. So if you give that option to the patient or the patient's parents, and they choose to go with that, and they were sure that they would be compliant with it, especially in the case of sublingual, because it can be taken at home, I think it's a choice that one should offer. And this is what is recommended in these guidelines. And the other important point is because there are so many products out in the market, and this is what we stated, allergen immunotherapy should be product-based. This is very important because a product has to be evaluated before you can say that it is effective in this. You cannot just make any product and with no studies, no evidence, you bring them out into the market and say, okay, you can use it because it is slit, and slit is recommended by APAACI, slit is recommended by WOW, slit is recommended by APAACI and American Academy. Yes, it is recommended, but it has to be product specific. So you see, there's so many studies and there's so much heterogeneity of the primary outcomes, the secondary outcomes, the products being different. And therefore, it is very important to have a product specific. So to highlight some of the key things out here, I'd just like to say that the minimum expectations of a product should be, it should have at least one successful state-of-the-art randomized double-blind placebo-controlled trial in adults, or in case of children, in children, to show the efficacy, and then additional claims can be justified subsequently. So at least one important DB-PCR randomized blinded, double-blinded placebo-controlled trial is necessary for proving that a particular drug immunotherapy product is effective. And then, of course, you should do the dose-ranging studies, and you should look at also the efficacy on the clinical symptoms as well as the immunological parameters. Now, without delving too much into it, just like to say that although immunotherapy takes time to act, and you have to tell them that patients have to be on pharmacotherapy while they're taking the immunotherapy, the important thing is that the onset can be even earlier. Onset of efficacy has been shown to be as early as 2 to 4 weeks and 8 to 16 weeks when it comes to the early phase response and the late phase response, as you can see in the data that's shown here. And that more time is required for a real clinical efficacy. But what is important here, I'll just show you here, that a minimum of 3 years is required for you to get, for a patient to get symptom-free period after cessation of the immunotherapy. This is very important to tell. Otherwise, some of them stop after 1 year, and they may have some relief of symptoms, but it's not of long-term. So more long-term relief of symptoms occur after a minimum of 3 years of immunotherapy. This is crucial. Now, what about the pandemic period? When we in pandemic, patients cannot meet physicians, clinicians, whether allergists or other organ-based specialists. They cannot meet them face-to-face. So how are we dealing with it? Well, telehealth was one of them. This is a publication by the APAACI statement here, as you can see here, and was said that if a patient or a person is actually infected by COVID-19, you have to stop the immunotherapy. There is no doubt. So interrupting both subcutaneous or sublingual immunotherapy is advised if the patient is diagnosed with COVID-19. But if the patient is already taking immunotherapy and is on sublingual immunotherapy, they can, of course, continue the treatment at home as long as they are not having the SARS-CoV-2 disease or the COVID-19 disease. But on the other hand, if they are, sorry, let me go back. But on the other hand, if they are free from the disease and they are treated and they now post-COVID, then you can restart the treatment after the disease. So we all know that SARS-CoV-2 particles are, the spike protein binds to the ACE2 receptor, but in allergic individuals, ACE2 receptor expression is downregulated. ARIA and YACI both recommend telehealth during, and that was work conducted very often, even in Japan, even though telehealth was never so common, but now patients also were reluctant to come to the hospital, so we would actually even have phone consultations. So in many ways, monitoring patients through mobile health is the future. M-health will be the future of treatment as we go on, just like the biologics are. So the possibility of expanding injection intervals for injectable immunotherapy should also be considered during this period, because you cannot give injectable immunotherapy at home. And of course, patients should be encouraged to be compliant with their treatment to prevent any disease flaring up. Now, just a few words about the comorbidity. As you can see, this is the first study in Wuhan showing that allergic rhinitis and asthma are not a comorbidity of COVID-19. And here you can see hypertension and diabetes. And we did a similar study looking at all the Asian countries. And you can see here also the common comorbidities were hypertension, diabetes, cardiac disease, and COPD, and asthma and allergic diseases were almost not there. This is in the first phase during the first burst of, or first episode of period of the COVID-19. And we have done a subsequent study also. So, like I said, in allergic rhinitis, we need to continue the treatment. Immunotherapy can be stalled, but pharmacotherapy can continue. Sublingual immunotherapy can be continued, but if the patients are infected, that should be stopped. What about asthma? Asthma, they are encouraged to continue their inhaled corticosteroids. Very important to keep this thing. They should differentiate between symptoms of asthma and rhinitis and COVID-19. All should have a written asthma plan, and nebulizers should be avoided to prevent the dissemination of viruses. So even in hospitals, we were not using nebulizers during the period of COVID-19. So in summary, I would like to say that allergic rhinitis and asthma are part of the atopic march, and comorbid conditions should be treated together in case they coexist, which often happens. And treating one improves the other disease. Care pathways, which I have not talked about today for want of time, are important to strategize the management of allergic rhinitis. COVID-19 continues to surge, but not now. I mean, now we are in a surge-free phase. Most of the countries across the world have good control, and we hope that it will not surge anymore and may become like an endemic. Asthma and allergies are not common comorbidities with COVID-19, and managing AR and asthma during and post-COVID is crucial. And finally, I would like to invite you to APAAACI's 2022 Congress, PAAACI at 15, that will be held in Manila, Philippines from the 5th to 8th December 2022. The World Allergy Organization Congress will be held in Istanbul in Turkey in October 13 to 15, and APAAACI will be held in December in Manila from the 5th to 8th of December. So we welcome you to both the congresses. Thank you very much.
Thank you, Professor Ruby, for the really excellent presentation. And I don't say this lightly. It was really, really very encompassing and very informative. If you may, could you also perhaps highlight some of the relevance of the environment? As you know, 2 days ago was the World Environment Day, and you have a huge body of work talking about environmental pollution and its effect on allergic rhinitis and asthma. Perhaps just a couple of words on that. for our listeners?
Yes, Dr. Kavita, I mean, very important question. In fact, as you know, APAACI has taken this as a very important action item. We have published a white paper on air pollution, climate change, and biodiversity in Asia Pacific, which actually carries the largest burden of this in the world, I would say. And we also had the APAACI Allergy Week, which you all were also a part of. And this was done in collaboration with the United Nations Environmental Program, highlighting how important the impact of climate change and air pollution is on allergic diseases, not just respiratory, but also skin allergies. But having talked about respiratory disease, yes, air pollution, as you can see in many countries, causes worsening of asthma. And you find that in many countries, especially in winters, during the fog, the children have to have like days off from school because the pollution is so high that they are almost having asthma attacks so frequently during that time. And we also know during the COVID period that pollution levels had really gone down during the lockdown. And on the other hand, having said that, it was outdoor pollution that went down. Many people still suffered from indoor pollution because they were exposed to the indoor allergens like house dust mite or cockroach, which is prevalent in many countries, especially in the Asian Pacific region, I would say. So any form of pollution. Then there's pesticides. We don't talk much about pesticides. So a variety of different things. Then there's climate change causing thunderstorm asthma, again, which can worsen. So the changes that are occurring in the environment directly impact the human health. And I would not even limit myself to allergic diseases. It's beyond that. It causes a variety of non-communicable diseases. So climate action, especially in relation to health, is crucial because health is the most important thing for the well-being of a person to be able to function. So I would really say that the environment plays a very important role. And also environment can interact with the genes by epigenetics and cause changes in the genetic profile and cause disease development. Also, it can also affect the epithelial barrier and then make it more vulnerable to having interactions with or dysbiosis with the microbiome. So it's a huge change. So I think targeting the environment is very important. And as APAACI, we are committed to take this forward together with the United Nations.
There's a lot of things to digest and swallow there. If you could give just some practical tips to our listeners out there, we are all bombarded with climate change. There's nothing much individually we can do about it maybe today. It requires a larger action taken by governments and political will. But we're also, some of the allergic individuals are just suffering every day. What could be some practical tips that you can offer them, Prof. Ruby?
Yeah, I think you raised a very important question, which has been close to my heart. And I spoke about this when I was speaking at the United Nations Biodiversity Conference, Rio Plus 20 in 2012. I was on the panel there at the United Nations. And I think that climate change or climate action is an action by multiple stakeholders. So we tell everybody, the governments have to do, the policymakers have to do, United Nations has to do, WHO has to do, our ministries. No, it's not that. Urban planners have to do, architects have to do, healthcare providers, civil society has to do. For example, when we are dumping garbage, when we are throwing our PET bottles, when we're using plastic, everything matters. Microplastics has become a very important pollutant nowadays. So the civic sense, the civil society also has to play. Each one of us has a role to play. How do we protect ourselves? Well, on a day-to-day basis, we can avoid highly polluted areas. We can try to keep our homes as free from by monitoring the air quality. We have got air purifiers. There are many different ways on an individual basis we can try to keep ourselves. But I think there is an individual responsibility of each individual citizen in the world. As a global citizen, we know that what we do, our actions are causing this climate change. And we have done this damage over years. And we want to rectify it in 10 years. How do we expect that to happen? It's very difficult. But each one of us has a social responsibility to act. And that's where I put a call as APAAACI president that we have to act at our individual level to be sure that every action we do does not contribute to air pollution, to climate change. And then as multiple stakeholders, we come together to act and work together to make this climate change stop, and that we have a better world, at least for our future generation.
It was a loud and clear message, Professor Ruby. So here you have it, listeners. Once again, on behalf of the Malaysian Society of Allergy and Immunology, I would like to thank you very much, Professor Ruby, for your time and for your knowledge sharing. You're very generous in sharing your knowledge and a lot of practical tips. And we hope that you'll enjoy, all the listeners out there will enjoy the content that we are going to provide to you throughout this week during the Malaysian chapter of the World Allergy Week 2022. With that, if you allow me, I draw this session to a close and wish everyone a very pleasant day ahead. Thank you. Thank you, Professor Ruby.
Thank you. And it was a pleasure to be there and pleasure to talking to all the audience. I'm very happy to take questions later on also by email.
All right.
Thank you.